I'm Dr. Chip Lavie. I'm a preventive cardiologist at the Oshna Clinic in New Orleans and done a lot of work on exercise and obesity and general preventive cardiology.
Hi, everybody. I'm Bob Eckel. I'm a professor of medicine emeritus. I'm an endocrinologist by board certification, but also had a joint appointment in cardiology. And I've been privileged to be co-chair of this Cardiometabolic Health Congress now for 17 years, and it's been a privilege to be here in this program that we are addressing inflammation and its relationship to cardiometabolic health.
I'm Pam Taub. I'm a cardiologist and professor of medicine at UC San Diego, and my research focuses on cardiometabolic disease, both lifestyle and pharmacologic therapies.
Hello, I'm Virend Somers. I'm a cardiologist at the Mayo Clinic in Rochester, Minnesota, and my interest is in sleep disruption, and how sleep, both healthy and disordered, can lead to an increased risk for cardiovascular and metabolic disease.
Okay, so the theme today has been inflammation. And as we think about the evolution of the Cardiometabolic Health Congress, which is really a closing Venn diagram between metabolic diseases that relate to lifestyle, cardiovascular diseases that relate to lifestyle, and also ultimately now kidney disease, liver disease. And I think the brain's going to be part of this ultimately. So Pam, you got things rolling here and addressing kind of some of the issues that relate to nutritional therapy and approaching patients in terms of their inflammatory burden. You know, one thing I thought you said that was very practical and is kind of related to a theme that I've implemented in practice for a long time. It's not good foods and bad foods. It's a dietary pattern overall. And if I have a medium rare steak once a month, so what? You know, I mean, you don't have to look like you're going to a confessional to deal with a food that's maybe not part of a heart healthy diet. So your additional thoughts about that?
I think it's about what you do most of the time, and and that's what we need to focus on. So, you know, there's different ways of looking at it. I call it the 80-20 rule, that 80% of the time, try to adhere to a Mediterranean-based diet. And if you do that most of the time, you're going to get the cardiovascular benefits.
Now, when you do that, do we find that markers of inflammation are favorably modified?
So the Mediterranean diet has a lot of data that shows markers of inflammation such as interleukin-6, CRP, TNF are all decreased.
You know, one thing that I've learned from the Mediterranean-style dietary pattern that it's coming mostly from the Mediterranean area, Spain, many of the papers from Estruch's group there, is that the major outcome that was favorable was stroke and not so much myocardial infarction. Do you have any thoughts about that as to why stroke might be preferentially modified versus MIs in patients who are on the Mediterranean diet?
Well, I think there's a lot of factors that influence stroke. I think there's a huge amount of stress that also is implicated in strokes, increased sympathetic nervous system output. So when you talk about the Mediterranean lifestyle, it's more than just the diet. There's a pattern of increased physical activity. And if you look at how these societies function, they just have decreased stress overall compared to what we see in the US. They sleep more, they have an afternoon siesta. And I think some of that other lifestyle aspects, other than just diet alone, I think is probably impacting stroke. That's my theory.
Okay, gonna go over to Chip here in terms of physical activity. You know, one concept that didn't come across so much, this is not a criticism, just an observation, this whole issue of sedentary versus guidelines that relate to moderate intensity physical activity. Can you talk a little bit about the benefit going from a seated position most of the time, i.e. maybe 1,500 to 2,000 steps a day, and we know there are issues related to that, versus getting to the guidelines in terms of moderate intensity?
Yeah, so there's one, I mean, obviously there's physical inactivity versus being physically active. So a person who's getting so many steps per day or doing some regular exercise is going to be considered physically active. But there also is something to say about sedentary behavior. So prolonged sitting definitely also has adverse consequences. And so most of the studies show that doing heavy exercise does negate most of the benefits, at least most of the detrimental effects, at least statistically, of sedentary behavior. But the ideal would be to be both physically active and to avoid prolonged sitting. And many people are sitting for 8, 10, 12 hours a day. If you could get individuals to reduce their sitting time to 4 to 6 hours, or at least get up every 20 or 30 minutes, that would be a tremendous benefit.
What about the gradient effect on, say, hsCRP or IL-6 or IL-1 beta? Is there a gradient effect, or is this a threshold effect?
No, I think there's a gradient. I don't know much about hsCRP with sedentary behavior, but certainly exercise reduces CRP, and a tiny amount of exercise would reduce CRP a little bit, and more significant exercise will have a greater effect. I don't think there's that many papers on a detailed dose response, but certainly 5 minutes of a slow walk is not going to be the same as a 30-minute jog regularly on CRP.
I'm going to use a metaphor of women who, in fact, were carefully studied in Stanford who were physically active, and unless they lost some body fat during exercise, their HDL didn't go up. So how important is body composition in terms of the impact of physical activity on inflammation? Can you comment on that?
I mean, certainly visceral adiposity appears to be worse on the cardiometabolic profile than is subcutaneous fat. I do think most of the studies have shown that you do get improvements in, for example, HDL and reduction in triglycerides that is independent of changes in weight. And at least in our cardiac rehab papers, we did not see a direct correlation. Now, that's not to say that the obese people who have a higher CRP to begin with, they get more benefit, and those who are obese who lose more weight get more benefit. But certainly people who are not overweight or who do not change their body fat much will still get improvements in at least their triglycerides and their HDL cholesterol.
And their CRP also.
And their CRP also. But the CRP benefits do appear to be more in the obese patients than in the lean patients. Now, keeping in mind that right now in U.S. society, I think 72% meet criteria for overweightness or obesity, and in our coronary population, it's a much higher percentage than that. So we don't have. I think it's becoming more uncommon to be lean in our society and to be lean with coronary heart disease.
Okay, well, thanks very much, Virend. You know, your emphasis on stress today. Really, I expect you to talk more about sleep, and you really talk more about stress. And really, this is an incredibly difficult kind of thing to assess clinically. And certainly, it's another behavioral change in addition to nutrition and physical activity that we need to change our patients in terms of the right direction. So just express your thoughts about how we assess stress levels. Do you use questionnaires or surveys? And ultimately, what kind of intervention do you make to modify stress and its relationship to inflammation now in cardiovascular disease?
So stress, as you said, it's very difficult to measure. There is no quantitative measure of stress that you can hang your hat on. That's been the big problem. Yes. It's more of a subjective perception. There are different questionnaires, and you can choose whichever one you want. If you want to get acute stress, you've got the state anxiety questionnaire. Then you've got other mechanisms that people can use and have devised and have, to some extent, validated. But really, it's a question of what does the individual feel? Does the individual feel stressed? And then you've got to teach a person who says, I feel stressed. I mean, you could be a physician doing a job, and a colleague could do the same job, and you could be completely fine, and your colleague could be absolutely stressed.
It could be burnout, really.
It could be burnout,
stress in the medical care environment.
Absolutely. The contemporary measure of stress is a burnout. And that's very common among physicians, especially during and after COVID.
So relate stress to inflammation.
So that's a very tricky business, but if you take people and you create a high stress situation and you use FDG PET, you can actually see bone marrow activation and inflammation in the walls of the aorta in the stress condition. So there's something about being under stress that generates probably catecholamines, probably inflammation, probably cortisol, that causes an activation of inflammation, whether it's in the bone marrow or even in infiltration of the walls of the vessel by inflammatory cells.
But what you're suggesting is that despite this sophisticated technology to look at the bone marrow, what about circulating white cell profiles and things like that, or biomarkers like IL-6? TNF-alpha and other things.
So let's go to sleep deprivation, which really is a kind of stress. In fact, it's a classic torture kind of stress. That's what we do to stress somebody. Not we, but that's what it would be used as a marker of stress. If you sleep deprive people, Janet Mullington showed many years ago that as they get progressively sleep deprived, their C-reactive protein goes up.
Okay.
So there's good evidence that sleep deprivation as a form of stress activates inflammation. And again, sleep deprivation also increases your catecholamine levels. Noradrenaline norepinephrine goes up very significantly in healthy, young, sleep-deprived people. They get endothelial dysfunction, and presumably that catecholamine drive activates inflammation as well.
Well, I had the privilege of working with Ken Wright from
Yes.
Boulder. And
Yeah.
Ken, we did a lot of studies in sleep restriction, typically a week of only 5 hours of sleep, and then a week, crossover design, a week with, usual sleep, 7.5 to 8 hours. And boy, metabolic changes really do occur. Modest weight gain occurs. I'm not sure we've measured HSCRP. It makes me think going back to the database and taking a look at that to see whether that's been impacted by that.
Definitely look at Mullington's paper. And Wright's done some great work. And he is also going along to what Pam had shown, published data showing that sleep deprivation actually changes the microbiome. And so that the whole thing ties in together. Exercise, stress, inflammation, the microbiome, weight gain. And when you talk about weight gain, about a year ago, we finished a study of young, healthy people who were randomized to sleep deprivation for 4 hours a night of sleep and then normal sleep. We kept them in the hospital for 2 weeks or 3 weeks at each time point. These young, healthy people, when they were sleep deprived, ate 300 calories per day extra.
Yeah.
But the remarkable thing was, they should actually send that fat subcutaneously. They were lean, so that's the first place you send your fat, because that's what it's meant for, to store fat. The fat went to the visceral compartment, and we could see it on CT. 11% increase just over 2 weeks.
Wow.
Yeah, that reminds me of a study that we did, which was kind of a sidebar to what I did research-wise. And we did liposuction on basically normal weight women who just wanted their saddlebags modified. And so they were randomized to surgery versus no surgery. And the grant, this is an NIHR one, was funded for 3 years, and all the weight came back, 7 pounds came back within 1 year, and all went centrally. It didn't go into the subcutaneous areas. Now, they were happy with the liposuction surgery because, they reduced the fat either periumbilical or their hips, but nevertheless, there was apparently a metabolic cost, although we didn't see changes in biomarkers that were really representative. So just to summarize our session, I might mention just briefly, Mark Houston from Nashville covered the genetic predictors of inflammation and cardiovascular disease risk. In fact, went beyond inflammation, looked at a lot of genes that were modified relationship to diabetes and hypertension and lipids and cardiometabolic risk, and ultimately kind of summarized systematically a series of genes. And I think the bottom line is right now we're not really ready for genetic screening in everyone, but ultimately maybe we will be in a more targeted manner. And then Stephen Harrison talked about chronic liver disease, mostly specifically non-alcoholic fatty liver disease, the conversion to NASH, and really implicating fatty acids were a driving force coming from the visceral depot to drive the progression of non-alcoholic fatty liver disease. So overall, to summarize, and you've heard from 3 of our panelists here today directly, and I commented briefly on the other 2 presenters, how cardiometabolic risk relates with an underlying milieu of inflammatory markers and conditions that relate to inflammation. So I think this ongoing theme of the interaction between metabolic disorders, cardiovascular disease, and now the kidney and the liver, and perhaps even the brain, relate to ultimately inflammation either directly or indirectly. So we thank you for your attention to this program. Hopefully it's been beneficial in terms of your assessment and care of patients. Thank you.